ARDS, that is acute respiratory distress syndrome. So first of all, I should tell you that it is also known as non-cardiogenic pulmonary edema. It is also known as high altitude pulmonary edema. It's also known as acute lung injury. It is also known as stiff lung. Okay. It is also known as diffuse alveolar damage. There are so many names of this particular entity. Well, we'll talk about this disease. But before I talk, let us learn some basic concept what the disease is. For that, we have to learn the basic pathophysiology. The basic pathophysiology goes like this. This is the alveolus A. This is the arteriole of the pulmonary. And normally, as we know very well, that oxygen goes like this and CO2 comes out like this. This is normal. The basic problem in the disease is this diffuse damage to these capillaries, alveolar capillaries to be more precise. With the result, a protein-rich fluid accumulates in the interstitium. So the entire interstitium is filled with the liquid containing a lot of protein. So that's why the lungs loses the elasticity. That's why we use the term as stiff lung. Lungs are rigid, and since it involves the entire alveoli, that's why we call as diffuse alveolar damage, the word what I told to you. Now this is the normal what we discussed. Now the entire lung is full of interstitium, is full of liquid with proteins. Now what will the effect of pathophysiology? Well, we know very well this oxygen cannot go in. Why? We have read in our school days, oxygen is a water insoluble gas. But CO2 can very well go out because CO2 is a water soluble gas. So as the oxygen is not going inside, the patient will have hypoxia. But CO2 can go out, the patient will have hypocarbia. With the result, patient will develop type 1 respiratory failure. Now one more thing I like to discuss with you. In type 1 failure, PaO2 minus PaO2 gradient is increased. PaO2 is here and PaO2 is here. That is partial pressure of the oxygen in the alveolus and the partial pressure of the oxygen in the arteriole. Now this oxygen cannot go inside. That's why this gradient is increased in type 1 failure. So to nutshell, to revise, in this case hypoxia, hypocarbia and increased gradient will be here. Well, before I discuss more about ARDS, let me tell you some more basic concept. The more basic concept is, well, normal PaO2 is about 94 to 104, but for easy calculation I am taking 100 millimeter of mercury. Okay. Now normal, we are taking breathing from the atmosphere, and we all know atmosphere has 21% of the oxygen. Okay. So in the scale of 100 we are taking 21, in the scale of 1 we are taking 1, and this is known as FiO2. FiO2 stands for fractional inspiratory oxygen. So normal FiO2 is 0.21. For the easy calculation, I am doing a round off to 0.20, right? So this is normal PaO2, this is FiO2. So let's see what is the normal ratio of PaO2 FiO2 ratio. 100 divided by 0.2, this comes out to be 500. This is a normal ratio. Now let's proceed further. Now this entire space is full of water and proteins. Oxygen cannot go in. Now PaO2 from 100, it has gone to 60. 60 is where we start hypoxemia start, also called respiratory failure start. Now it has gone to this. Now ratio will be 60 divided by 0.2, 300. When the ratio is 300, we call as mild ARDS. Now he has become more and more hypoxic. The ratio has gone to 400. Okay, the PA, this thing, that means this CO2, O2 has gone to maybe 40. PaO2 from 62 it has gone to 40. Ratio 0.2 is 200. So we call as moderate ARDS. And the ratio now, this PaO2 has gone to 20.200. We call as severe ARDS. So this is a ratio decide 300 mild, 200 moderate, and 100 is severe ARDS. This is a scenario for this. Now, of course, there are many causes about which I discuss very soon. But let me discuss the treatment, how I'm going to treat the case. Well, one more thing, as the entire fluid is in the interstitium, these alveoli are clear and airways are clear, so there will not be no crackles, no crepitation because rhonchi are clear. Airways are clear, so there will be no rhonchi. So by and large, if you examine the chest examination shall be normal. Okay. Well, when I plan to treat, let's learn what the problem is. Oxygen can come up to this place, but oxygen cannot go inside. Why? Because it is full of water, and water is oxygen is water insoluble gas. Now remember, suppose he has got this ratio is 100. He has got severe ARDS. He is severely hypoxic. He is about to die, and I have to treat the basic cause for which is causing ARDS. But my aim is to put oxygen here. But how to do this thing? So now I recall my school days. In our school days, in our physics and chemistry, we are taught if a gas is put under pressure, its solubility increases. So I'll put this patient on ventilator, maybe PEEP, and I'll give with the pressure, and pressure will solubility will increase, and more oxygen will go inside. Now what else I can do? If I increase the PEEP, this FiO2, normal FiO2 is 0.2. If I increase to 0.4, that means more and more oxygen will go. Up to 0.6 of FiO2 we can go, but not beyond that, because otherwise it lead to more and more toxicity. Oxygen toxicity will be there. Now I hope you understood the basic concept about ARDS. With this background, now we come to the main topic. So it's the clinical syndrome. It's not a single disease caused by diffuse alveolar damage, as I discussed, capillary damage, and it is characterized by rapid onset of life-threatening respiratory distress. Now you understand the meaning of life-threatening, because PaO2 has gone maybe up to 20 also. Okay, patient may develop cyanosis because of severe hypoxia, and arterial hypoxia is there. But what a special thing, it is refractory to oxygen therapy. Now I don't need to tell you why, because if you are simple giving oxygen, it will not go inside. So simple giving oxygen, maybe by nasal cannula or by mask, will not carry any meaning. It has to be given by under pressure like PEEP, and it may progress to extra pulmonary multi-organ failure. This is about the basic concept. Well, we talk more about this thing. If you go for X-ray, you find diffuse bilateral. If you go for chest X-ray, you find diffuse bilateral infiltration, alveolar infiltration, especially in the interstitium. Okay, so diffuse alveolar damage is the hallmark, as I discussed just now, and lung damage and release of inflammatory mediator cause increased capillary permeability, and that lead to non-cardiogenic pulmonary edema, often accompanied by multi-organ failure. Why we call as non-cardiogenic pulmonary edema? Because usually the etiology is something else, not the cardiac reason. Well, what are the causes? Causes can be, this is due to direct lung injury. And this can be like in pulmonary, it could be pneumonia. It could be gastric aspiration. It's very common in GERD, or maybe after surgery, after anesthesia to be more precise. Toxic gas inhalation. Maybe lung trauma. And of course, vasculitis can cause this problem. Next, we have certain conditions so-called indirect lung injury. This is due to systemic illness. Like, for example, any cause of shock, whatever reason may be, it may be septic shock, or it may be septicemia, so-called sepsis, maybe severe hemorrhage, multiple blood transfusion, disseminated intravascular coagulation, DIC, pancreatitis, and acute liver injury. It may occur in generalized trauma, so-called roadside accident can cause this type of picture. Head injury can cause this problem. And of course, this can be caused by malaria, especially Plasmodium falciparum malaria. It can be caused by fat embolism, typically occurs with some fracture of long bone, very common in roadside accident, and this can be caused by multiple blood transfusion. In obstetric event like eclampsia or amniotic fluid embolism, this can happen. Okay, this can happen with drug like heroin toxicity. Okay, and cardiopulmonary bypass with heart-lung machine. Now, I have a question for you. This heroin, this can lead to ARDS. But heroin is notorious to lead to some glomerular disease. You can listen to questions, stop the video, write down the answer. The question is, heroin can lead to what type of glomerular injury in the kidney? Write down the answer. I hope you have written the answer. Answer is, it can lead to focal and segmental glomerulosclerosis? It's a very frequently asked question. Well, we move further. That the clinical physiology of ARDS, as I told you, one of the classical feature is it is of a sudden onset. And main problem is what, as I discussed, accumulation of protein rich fluid in the interstitium, as I discussed earlier. Well, pathophysiology of ARDS. Basically, there is a injury to pneumatocyte 1. And that lead to, and in addition, there is increased capillary permeability. This I discussed earlier also. And this how ultimately a protein rich fluid accumulated in the interstitium. This I already discussed in great detail. And ultimately it lead to hypoxia, and we get pulmonary edema, and there is a formation of hyaline membrane. It is nothing but fibrin and coagulated cell debris is there. Okay, and as I discussed, it lead to stiff lung. This is what I discussed in basic concept. And ultimate tidal volume is reduced. Well, now as I told you, in the chest X-ray you get diffuse bilateral infiltration. Same in scan also, you can see again bilateral infiltration is there. Well, high altitude pulmonary edema. It's a type of ARDS which occurs in those people who go to great heights, and suddenly patient can develop ARDS. What is the main reason? Pulmonary vasoconstriction is the prime mechanism by which this problem occurs. And remember, this can occur in both acclimatized and unacclimatized also. But it is much more in those who are unacclimatized and those people who suddenly go to great heights. That's why this is much more common in unacclimatized people, and it is exacerbated by exercise and associated with high cardiac output. Well, how we can go for ARDS? Of course, clinical ground is always the reason to diagnose, and in this case, what we have is cut. Stop. Start. So when we have to diagnose, what are the reason why and how we diagnose? First of all, clinical ground is there, and what is the main thing? It is sudden onset or acute onset. Acute onset of breathlessness, and if you go for chest X-ray, you get bilateral pulmonary infiltrate. And when you do the pulmonary capillary wedge pressure, which is an indirect measure of LA pressure, it is less than 18 millimeter of mercury. It's a very important point to know, because in cardiac pulmonary edema, this is more than 18 millimeter of mercury. Okay, and partial pressure of the oxygen and FiO2 ratio is less than 300. This is how we diagnose a case of ARDS. Just remember, when it is ratio 300, it's a mild ARDS. Less than 200 is moderate, and less than 100 is severe. This is a quick revision. And I told you, in this case, LA pressure is normal. And remember, in cardiac pulmonary edema, LA pressure is increased. This is the most important thing that you got to know. That's why I've repeated this second time. Now, basic concept of FiO2 I discussed. I don't need to repeat it again. The clinical feature of ARDS is patient has tachycardia, increased heart rate, increased respiratory rate, that is tachypnea is there, cyanosis is there, and but in chest auscultation, when we don't get any rhonchi and no crackles, this point I discussed earlier. Okay, mild, moderate, this is again thing we did earlier. Mild, moderate, severe ARDS. This we covered with the basic concept. Well, the important point, diagnostic criteria of ARDS, what I discussed earlier, that we are getting sudden onset and severe hypoxia is there. Now, how to manage a case of ARDS? First of all, these patients should be treated only in intensive care unit where we have facility for ventilation. It's mandatory. Treat the underlying cause, okay? But remember, cause cannot be treated in 1 hour, 2 hours. But patient is critically ill. He is about to die in a few minutes. So we have to give oxygen as discussed in the basic concept. You put the patient on pressure support. CPAP is there. We can give 40 to 60% oxygen. That means you have to increase FiO2. For sepsis, give antibiotic. Nutritional support, high fat antioxidant should be given, and we can give a shot of steroids. Protect those who are at risk of fat embolization and with pneumocystic cardiac, may improve outcome in subacute ARDS also. But it is not a definite treatment, it is just a supported treatment. Okay, and as I told you, in the initial stage of ARDS, we can use CPAP. But otherwise, most of patients, they need PEP, positive and expiratory pressure. And what is the main thing? You have to give low tidal volume. Low tidal volume. PEP. That means it should not be more than 6 ml per kg of ideal body weight. So it should be always low tidal volume, because if you give high tidal volume, it can lead to barotrauma to lungs. And as I told you, even FiO2 we can increase, but it should not be more than 0.6. Otherwise, it will lead to toxicity by the oxygen. Okay. So PEP should be given. Most of the things I discussed during basic concept. That's why it is much easier to discuss now. So what is our ultimate aim? We want that PEP pressure should be kept how much? 15 to 20 centimeter of water. And we want that oxygen pressure should be somewhere in the range of 55 to 80, and saturation should be around 88 to 95%. Okay, we want that saturation should be at least more than 88%. And overall mortality is about 50 to 80% mortality is there. Well, a quick recap of the last minute revision point. ARDS is also known as acute lung injury, non-cardiogenic pulmonary edema, diffuse alveolar capillary damage, caused by direct lung injury or indirect lung injury, which is systemic illness. Important cause include septicemia, liver disease, plasmodium falciparum, heroin, HEP, and sudden onset of dyspnea is the main feature. And there is accumulation of protein-rich fluid in the interstitium. LA pressure is normal, that is pulmonary capillary wedge pressure is normal. Type 1 failure is there, reduced compliance, diminished tidal volume. Normal FiO2 is 0.21, and in this case, when the ratio is less than 100, it indicates severe ARDS. Management is antibiotic, steroid, low tidal volume ventilation, increased FiO2, and PEP has to be given. Thank you very much for watching this video.